started thinking about how I was training other people. Because I had just gone through the learning curve, and then when you think about training, there's a different element to this. So I have training 3 people to do ESD at the moment, and I just did some reflections and put them into a slide formation. So the first thing to do is you need excellent tip control, and you need excellent KPIs because they are surrogate for your scope handling. And as you've seen, scope handling and tip control are the building blocks on which you build ESD. I think you need to be competent in large complex polyp resection because you then have a better understanding of planes, a better understanding of diathermy. You should come with that in your locker already. And then I think there are the personal qualities which makes the trainer and the trainee have a really good relationship. You need to have the humility to receive the training because undoubtedly you will be a very talented individual. And you're usually the best at everything and you get an A star and you're just generally good at everything. And then suddenly you find yourself in an arena where, quite frankly, you're not. It's a learning curve. And if you're not used to being honest with yourself and have the qualities to receive the training, you're going to make very slow progress for 2 reasons. I guess you get used to what you get used to, which is another thing in ESD. If you go to Japan and get trained in Japan, they tend to train you in one technique and you use one knife. And when you get good enough to do all of that, you start branching out. So my advice would be try and simplify things and become very comfortable with the instruments and the equipment you're using. What I witnessed yesterday is you're pushing the scope in and advancing the knife and lifting the knife out. And what that does is it's very safe because you lift, therefore you lift away from the muscle there, you make a small cut, then you repeat, then you repeat, then you repeat. If you get very good, you can keep your knife within that plane and it probably gives you a continued incision. There are other ways to do it, parallel towards or away from the muscle there, and they require different skills. So if you're coming away from the muscle there, what happens is you pull away. And then I wanted to think about a little bit about what you're really trying to achieve here. So obviously the idea of ESD is we get an on-block precision of something, okay? Ideally without any complications or muscle injuries, right? And then you just go down the list. So there's an on-block resection with some muscle damage not requiring any treatment. So we got a little dab here and a little bit dab there. It's probably okay. It doesn't require closing, actually. In fact, when you tend to resect the lesion, the muscle there closes over and it minimizes what damage you've already done. But you have to recognize when you've got a dab and when you've got a breach that requires a clip. If there's significant intraprocedural bleeding, sometimes it's unavoidable. I say that probably because we're technically not good enough to spot the vessels early enough. And I think a measure of how good you are is how often you have a significant intraprocedural bleed. And I think as you get better, you're much better at isolating the vessels and stopping the bleeding before you start. We don't always get it right, so you will get some bleeding, but I think if you're having a lot of procedural bleeding, it means your technique needs to probably improve a little bit. And obviously, you can have an on-block with both bleeding and perforation. You took it off on block, but you've had a lot of casualties on the way. And then when you bail, we do something called a car. So we convert it. We either abandon it altogether or we take a snare and take it off. So you're aiming to be at 1, but we recognize for each of your lesions, you might come further down the list. And then you have to go back to what I was saying earlier about the technical challenges associated with the polyp and the access. And have you noticed I haven't mentioned size, right? Size is relevant in terms of time, but the technical difficulties really relate to the polyp morphology and the access more than the size.